Good morning and welcome to yet another episode of the Lumière Learning Monday. I have two fabulous women here as my guests, Dr. Vanita Noronha, who is a senior consultant medical oncologist at the Tata Memorial Hospital, and she has actually established the Geriatric Oncology Clinic in Tata Memorial Hospital in 2018. And my other guest is Dr. Anita Kumar, who has been a passionate supporter of seniors and geriatric care. She speaks at different fora, she writes avidly, she also has her blogs. And meeting of these two people is probably one of the best things that has happened for the first ever geriatric oncology multidisciplinary service that was introduced by Tata Memorial. So welcome and thank you so much for for this very rare, very serious, and important topic that we're going to be talking about today. So, thank you so much for coming.
Thank you. Thank you so much for having us,
Thank
Lisa.
you. Thank you.
So, Dr. Vanita, I want to ask you, when did you get interested in oncology and why oncology? So,
So I guess it was serendipitous. So the this it is this is an issue when we do MBBS. So I did MBBS in India at GS Medical College in Parel, and we actually have no exposure to oncology in our MBBS and also during our MD time. So internal medicine in MD time as well in India, there's really that this is a lack. After my MBBS, I went abroad. So I did my MD at State University of New York in Buffalo. And at that time, I had we had, you have automatic rotations. So I had a rotation at Roswell Park, which is attached to State University of New York in Buffalo. And that's actually quite a very prestigious global cancer institute. And that's where I actually started developing an interest and a love for oncology. This
wow.
seemed to me to be such a challenge. Cancer is always this big mystery. How do you solve it? And all of us have this scientific bent of mind, and all of us think, I'll be the one to cure cancer. So it started with a very naive optimism, I would say, but it has grown since then. And I did my oncology training in the US at Yale Cancer Center, and then I returned to India and joined Tata Memorial. So I think that's the story of my interest or love for oncology, I should say.
Amazing. And now, how many years at the Tata Memorial Hospital?
So I joined in 2009. So that would make it 13 years, I think. Yeah.
Yeah, yeah, yeah. And after, did you know that you were coming back to India? Because so many doctors go abroad, they go for their MD, and then they continue to be there. So, did you have that in mind that you were coming back to India?
Yeah, absolutely. So when I went to when I initially went, I wasn't sure, but I did go on a J1 visa, which is an exchange student visa, and you automatically need to come back. But there are always hacks and there are ways to get around it, and people convert it to an H1 and things. So I wasn't completely sure, but I did know that I want to come back. And then I met my husband in the US, and he also wanted to come back. We did lose our way along the way. It was so weird. I did my oncology training at Yale, and at that time my husband was working. So he's from IIT, and then he had joined a startup in Silicon Valley. And he always had this thing that I wanted to entrepreneurship, and I said, do it now. If you want to go back and study, do it now. And he said, no, baad mein main karunga. And then I completed Yale, and then he said, I want to do MBA. And he applied to Yale, and then he got admission in Yale when I left Yale. So our timings never quite think. So I did private practice for a couple of years. He did his MBA, and then but we both wanted. Our parents were older. We always felt we need to come home. So it was a mutual thing, and we came back.
Yeah,
So
what
as
love.
soon as he finished, his MBA, we came back to India.
Amazing, amazing. I'm going to turn to Dr. Anita now. Dr. Anita Kumar, what attracts you to geriatrics? What makes you like the cause of seniors? We can't hear you for some
I'm
reason.
not sure if you can hear
Yeah,
me. I hope you
now we
can,
can.
though.
Now
Uh,
we can.
and yeah, so I have been attracted to this field from a very long time. Actually, it probably starts from me being a child living with my grandparents, etc., and the love for that, love for them. It was just obvious, sort of in my head, that I was going to get into something that dealt with elder care. I didn't know what.
think there is a pause there.
Probably I would have thought even social work, or even in MBBS. When I was doing MBBS, uh, wrote a I wrote an article where I spoke about elder care, and I mentioned this word geriatric care. And I was in that, and that time there was nothing like geriatrics, and there was no course or something that. But by the time I finished, I think there were 2 3 years of geriatrics had just finished. So which means that I almost wrote my future of sorts. And
Amazing.
I mean, that was a very funny incident, because years later, I mean few years later, when I went back to what I had written and what my blog posts and all that, I said, oh my god, I actually wrote about geriatric care, and I'm doing geriatrics. So it was, I don't know what word you would say that, but
Yeah, yeah,
yeah,
yeah,
I
yeah, yeah.
kind of wrote my
Yes.
future.
Yeah, absolutely. You sort of envisioned it, and you made it happen, and you made it materialize. So that is
Yeah,
beautiful.
yeah. And I
Yeah,
didn't even know about it.
yeah, yeah. And sometimes I think maybe you're such an interesting writer. So when you think of writing, I always think of a doctor, and there is this amazing book on cancer that's written by Dr. Siddharth
Siddharth Mukherjee.
Mukherjee, and I'm thinking how all of that comes together, where you're bringing in or Atul Gawande, where the medical field and the writing comes together, and you tell powerful stories, because you're always, I guess, in the face of stories, isn't it, Dr. Vanita and Dr. Anita? Because it's like real everyday cases, and every case is a story for you. So, tell us about this thing of coming into Tata Memorial Hospital and being able to influence the setting up of the geriatric oncology service for older patients who are 60 and above. What was the genesis? How did it start? And where are you right now on this?
So I would say, let me go back. So we started in 2018, but the idea has been in my mind, had was in my mind for several years. The geriatric oncology is unfortunately not a recognized stream, or not,
Hmm.
not a recognized situation in India. So older patients are treated the same as younger patients with cancer. Most of how we treat our patients, all of that comes from clinical trials, and by and large older patients are excluded from clinical trials. So I don't you know
Correct.
we offer treatment and we plan treatment for older patients without any kind of real evidence based guidelines. And they also, other than the cancer directed treatment, they have so many other issues, vulnerabilities, cognition, function, etc. But there isn't this phenomenon that you need to take care of older patients in a different manner. It's a very well recognized phenomenon of younger patients. So pediatric cancer is very well recognized, very well appreciated and funded, but not so for the other extreme of age. So it had always been in my mind, and I'm very very fortunate to be in a unit and in a department that permits people to actually design things that think that will improve patient outcomes. So really fortunate, Tata Memorial is a very is very open to starting,
Mm.
having new ideas and starting new clinics. So we started in 2018. So a colleague of mine, Dr. Anant Ramaswamy, and I, we decided, let's start it. But when we started it, we knew nothing. So I,
Mm.
I downloaded a few articles and I read about it, because we didn't have any formal training at all. So we said, and we kept postponing. I have to say, for a few months we kept postponing, saying we'll do it next week, we'll do it next week. Let us study some more. But then I said, it's never going to happen. Let's just start it. So we started it with we did a few tests, and then we kept reading and kept expanding it. In the beginning, it was really difficult. So I would send my own patients. So any patient in the other OPDs that I would cover, I would say, I'll come to my geriatric clinic. And so those were only my patients and Anand's patients. And then every week, so we started it once a week on Wednesdays. And I
Hmm.
used to sit there for 3 hours in the OPD, and there were no patients. And then I used to call around in the hospital, do you have any patient who's older? Please send that patient. So it required some buy-in, and that was difficult. Nobody recognized that to start with. But I have to say now, the buy-in has been tremendous.
Yeah.
In between, prior to when Dr. Anita joined us, there was a waiting list. So patients, we had to then give them appointments. So we expanded the clinic to twice a week. Then we expanded it to every day. And then we had an appointment system and a waiting list, and the waiting list was going into 2 and 3 and 4 weeks.
Wow.
Now it's far better. So now we evaluate patients in a day or two. But I have to say it has been a learning experience. And then we had buy-in from various. So it's a multidisciplinary team. So we
Yeah.
have medical oncologists, we have geriatricians like Dr. Anita, there's a Dr. Abhijit. We have the physiotherapist, occupational therapist, dietitian, psychiatrist, clinical pharmacologist, volunteer, social worker. So it's a huge team. And,
Yeah.
each of those teams joined us gradually along our journey. So now I think we have a really nice, vibrant clinic.
Yeah, I saw some pictures on social media of your entire group, and I thought it was a very happy looking team that's
It
obviously
is.
getting some great outcomes.
It is. Anita,
Amazing.
you tell us how happy our team is. It's like a mini family, isn't it?
Yeah. So, Anita, what do you have to say? How did
Yeah,
you
we
how did you meet, and how did you
are
find this piece? How did you become the
very
piece of the
happy. I
jigsaw?
must say, yeah, it is a mini family, which is
Yeah, you
Now
were
we
getting.
can.
Now you are.
okay. So I just wanted to say that yeah, we are a big family of sorts, a mini family of sorts, and that is the reason I wrote the article that I did, and I did mention how important each individual of that team is, and each individual of that team is making all efforts, going all out to ensure that the geriatric patients are taken care of, which is why when we send patients from our area to another area, we call them and tell them that my patient is coming, you see. So there is a link, and there is a continuous, there is a circuit that happens, and it's not that just we tell the patients you go and they are then searching somewhere else what to do and what not to do. We are giving them the good guidelines, good proper where to go, what to do, when to do, etc. We take appointments for them from here, from where I am sitting. We take appointments and then we send them, so that they are not lurking around somewhere
Yeah,
wondering what next.
yeah,
And that is what is so special about this clinic, is that we are all involved, we are so involved. Each individual is so dedicated on the team, it's unbelievable. You will not find this kind of at least I feel that you will not find such dedication anywhere. It's
yeah.
just each one is so involved in the whole process, and everyone is so good at that work, their own work now. So when such things come together, it just feels so right. You just want to come to work every day. There are days when I have leave and I feel that no, I don't want to be on holiday, I want to go work. But
Okay.
seriously, I just love doing what I do.
So I want to understand. I was reading about the three pillars of geriatric oncology that are patient care, research, and education. So would one of you throw a little light on how these three pillars come together to serve the patient?
Absolutely. So I can start. So those, I think we have kind of borrowed that concept from, this is actually the mission statement of Tata Memorial Hospital, Tata Memorial Centre. So we have these three pillars of service, education, and research. So I kind of borrowed from that and made it the motto of our clinic as well. So service is what we are doing every day. So taking care of patients is our service. So starting the clinic, what we do every day, when in the clinic we evaluate patients, look for vulnerabilities in various domains. So we call them these geriatric domains, which include cognition, function, falls, nutrition, psychology, medications, comorbidities, fatigue. So we have all of these domains. We evaluate these domains. We say, this patient has cognitive impairment. Let's see what we can do for that. Or this patient would benefit from a psychiatric evaluation because there's some evidence of depression which is not obviously recognizable. So that would be service, and then we send them to the various departments, design interventions for that patient, see the patient back, see if they have benefited from that intervention. So that's service. That's a huge area of need, and that's the immediate need. So in terms of cancer care or any kind of medical care, that's the most obvious, and that's what we deliver, service. Education is a phenomenon that is very, very important, especially in geriatric oncology, because this is not recognized Globally, and globally there is some recognition, but it is not as it should be. But in India, that recognition is almost zero. So nobody
Hmm.
understands. So education is for other healthcare professionals as well as for patients and general providers. So in terms of other healthcare professionals, other medical oncologists, surgical oncologists, radiation oncologists, that you need to treat an older patient differently. And how do we get that message across? Through education. So we as after we started our geriatric oncology clinic at Tata Memorial, we realized that we need to educate people. So we started the Geriatric Oncology Fellowship Program. There's no other fellowship program in India currently,
Wow.
and that's how we have got Dr. Anita, Dr. Abhijit. So we train one fellow a year, but that's clearly not enough. The idea is to create a cadre of healthcare professionals, medical oncologists, geriatricians who are skilled in taking care of older patients with cancer. But that's not enough. So other than that, we have online workshops twice a year. We have partnered with SIOG. SIOG is a global geriatric oncology body. So
Hmm.
we are having an advanced online course in geriatric oncology. So it's a Tata Memorial and SIOG collaboration. The
Hmm.
first workshop we will have in November, so next month. So that's education. I'll ask Dr. Anita to speak on education as well, because she does a whole lot of education in terms of educating public and doing that. And in terms of research, now research is huge area of unmet need, and there are multiple requirements for that. But just in brief, the all of our treatments, most of them we have not studied in older patients. So do we know that the chemotherapy has the same effect in older
Yeah.
patients? Do we know if it has more side effects? We don't know, or we almost know nothing. It's and the problem is that older patients have so many other issues, so we don't normally include them in trials. So then how do we find out? How do we take care of them?
Right.
So there are no trials, there is no funding for those trials. So that's another area of huge need.
Yeah, wow. I mean, that's amazing. So, Dr. Anita, do you want to talk about the whole education piece? Because not only the community, I think it's also uh, the caregivers. Both there is individual as well as societal education that you're involved in, isn't it? Like involving, creating, raising the level of awareness through all the talks that you do. Dr. Anita, you can hear me?
Yes, yes, exactly. So, am I on a lag period? I don't know.
Yes. Yeah, we can
So,
hear you
okay.
now.
So, there are lots of talks I do, which are national, international spaces. I have done it uh, on all aspects of geriatric care. But now, since I'm involved with Tata Hospital and I'm interested in oncology care also for the elderly, so I do address a lot of caregivers in various forums, and I address a lot of patients with elderly patients with cancer. Idea is to provide awareness. Idea is to let make them understand what it is. Idea is to let give them the hope and strength to continue life, because life is not going to end. No
Yes.
doctor in India or abroad or in America can tell you that you are going to live for 10 years, 15 years, or 2 months or 3 months. Okay,
Correct.
there might be some calculations, but it is not foolproof. You can't say that, okay, so now you have got this disease, so you're going to live for 5 months or 6 months. No, because you can extend that, you can break that. If you
Mm.
have good mental strength and good physical strength, good emotional strength, you can break anything. And I personally believe you can fight any disease in this on this planet, and I do believe it
Wow.
sincerely. I tell this to almost every patient of mine. There are so many patients who come who are very depressed. Once they get to know that this is a disease, they're all depressed. That is
Mm.
not I mean, that is, it's not end of life. We are going to work with you. We are going to My aim is to handhold these patients and take them from the not so well state to a slightly more well state. That's
Yes.
the aim.
Yeah.
And providing awareness is the first step, I think. And after that, it is all is the rest, treatment and all comes next. But first is awareness, because as soon as they get to know about the disease, they are very depressed. And that's
Yeah.
something we need to tackle. And I'm tackling it through writing lots of blogs, which a lot of
Yes.
people have been reading. They have been coming back to me, they have been asking me questions about what it is, where it is, etc. And I've been telling, like you yourself have sort of seen
Yes,
regarding
yes.
our, yeah.
Yeah, one of the talks that I saw was where you were talking about the importance of assessments and why are these assessments done for seniors. And I think the entire talk focused on this aspect of assessments, to the point that you were making, Dr. Vanita, right in the beginning, that we have to then identify what is the right kind of line of treatment when you're treating the cancer. So, how tedious is this process? How important is this process? How receptive is the patient to this process? And maybe you want to talk a little bit about this. And also, is this always curative in nature, or are these assessments also preventive?
So I'll answer that first. It is tedious. It takes a really long time, and that's the crux of the problem. That's why healthcare providers and medical oncologists across India do not do a geriatric assessment. It used to be called a comprehensive geriatric assessment earlier, and just I think just that name put people off. Comprehensive geriatric assessment. So I think globally. The nothing about the assessment changed, but globally the decision was made that we will scrap the word comprehensive and just call it a geriatric assessment. So when we started, we initially audited our first couple of years that we were doing the geriatric assessments. It took us a median of 50 minutes. So
Okay,
it takes a long time. So, and it's not a curative or a palliative thing. So it is an assessment of non-oncologic vulnerability. So not cancer related. So
got it.
vulnerabilities because of old age in older patients, regardless of the presence of cancer. Um, I To answer your question about curative and palliative, in cancer care, we have this thought process of curative and palliative. Curative meaning the cancer can be completely taken away and we expect that it will not come back. And palliative meaning the cancer can be treated, but not completely. And so our goal is to prolong life or improve quality of life. So patients, so we went and asked that questions, and we asked the question to our older patients with cancer. So this was one of our studies that I had presented last year at SIOG as an oral presentation. And so it was such a simple concept. Older patients, when they are in the curative or the palliative setting, what is most important to them? In younger people, in younger patients with cancer, it's always survival, and all most of our primary endpoints for all of our trials is prolongation of survival. So, but we asked our older patients, and 90% of those patients said we want better quality of life and not prolongation of survival. We are okay with even a little bit less survival, but we want to live better. So that's it's
Wow.
so much. It's a different thought process completely.
Very, very interesting. In this profile, now that you've had the clinic going for some time, tell us a little bit about what's the kind of patient profile that comes to you in Tata Memorial. Tata Memorial is always gets patients from all over the country, right? And there are people from all strata of society. So, for geriatric oncology, is there some kind of a skew you see, or how is it that if you can tell us a little bit about that?
So, in terms of Tata Memorial Hospital, yes, we do see patients from all over the country. Our director, Dr. Badwe, has been a very forward-thinking gentleman, and he has actually started a lot of, to try and decompress this. He has started Tata hospitals. All there are multiple now, all over India. So that is has improved things, but certainly we register maybe about 40,000-50,000 patients a year, and we have found that a third of those patients, so 28% of the total number of patients that we register at Tata Memorial are actually in the geriatric population. So that's a
Wow,
huge number.
huge
Uh,
number.
yeah, in regarding the patients we see in our clinic, it is a bit skewed. It still has all our clinicians have not yet completely bought into the idea of geriatric assessment. So do we assess 100% of the older patients with cancer at Tata Memorial? No, we don't. We assess all patients who come to our clinic. And that is a bit skewed. The people who believe in geriatric oncology send all their patients, and some don't. The majority of patients we see are from medical oncology, because both Anant and I are medical oncologists. In Tata Memorial, we have surgical oncology, radiation oncology, etc. But that is changing. We are seeing more and more patients, but still not definitely very, very, very far away from 100% of patients who need it.
So, in terms of the call for action, and that's, in the last few 5 minutes, I want to focus on that. What would be your call for action for three cohorts. One is the medical fraternity. The second are people who would be funders, donors, and the third would be the cohort of the lay public, either who have a propensity to the illness and are seniors, or people who are already suffering have been identified and their families. So if we can bucket that, the call for action for these three cohorts.
Sure. Sorry, the first cohort was for
The doctors, the medical fraternity.
Okay. So I think, and this is what we have been trying to propagate from day one, that geriatric oncology and geriatric assessment is very important. And older patients with cancer have to be assessed differently. And that is something that is very difficult to do in the routine clinic. So, so when I'm sitting in a busy OPD and I'm seeing maybe 100 patients a day, I can't sit down and do a geriatric assessment. So there needs to be a specialized geriatric oncology setup that is separately evaluating your patients. So that's number one, and that is very important. Gain the expertise. Most of our medical oncology training programs do not incorporate geriatric oncology as a separate specialty. And if one in every three patients is older, that is so important. I mean, that's critical. You need to know how to take care of these patients. So that's one for healthcare professionals. The second was for funders. There is a huge requirement for funding. We require funding for so many different aspects. So in terms of education, if we had funding for more fellowship posts, in terms of research, in terms of patient care, if we, patients require walkers, they require various other instruments. So there's a huge requirement. So even a little bit goes a long way. So that's in terms of funding. And the third was in terms
The
of
third is just, yeah, patients and both lay public.
Yeah, so I think in terms of patients, ensure that your doctor has, if you're a patient and you are older than 60. So that's another point. In India, the life expectancy is shorter. So globally, the age at which geriatric age group starts is different. So that cutoff is different based on your country. So in India, it's 60 and above. In US, it's 65. In Europe, it's 70 and above. So that varies. So if you are a patient who is 60 and over and has you have been diagnosed with cancer, ensure that the doctor who's taking care of you has some expertise in geriatric oncology, or get yourself assessed by somebody who can do that, because that can really improve your quality of life. It can really improve the type of care that is delivered to you.
Yeah, yeah. And for
Anita?
people, who, Anita, when you are writing blogs to the public, yeah, what is it that you're seeing? How is the needle shifting from the work that you've been doing in sensitizing the public to geriatrics and now to geriatrics oncology?
Geriatric oncology, I'm just focusing on the cancer aspect, but otherwise, it's very general. It's general to the layman. It is very general. I mean, I'm telling them what to do, how to go about various aspects. And I kind of lost your question. What was
Yeah,
your
no,
question?
so basically the call for action when you're doing this, when you're writing, there is a certain shift that you're looking for in mindset, in attitude, in behavior. How would you know that the work that you're doing, all this effort that you're putting, is shifting the needle towards either, more awareness? What are some of the shifts that you would want? What is it that you proactively want people to do, the public to do, so that we know that this is becoming a very mainstream awareness aspect. It's like saying I need to go and get my dental checkup, or I need to go and get my eyes checked. So something as routine as that there should be something to check or do this geriatric assessment.
So what I am expecting from the patient eventually will be for them to come themselves and understand that they need the a geriatric assessment done for themselves, and for anybody above 60, or they refer somebody who is above 60 to for a geriatric assessment. Either you get a geriatric assessment. I mean, a geriatric assessment can be done for any disease. For every disease it can be done. In our setup, we are doing it for oncology patients. We are doing for all medical, surgical, all types of.
Anita, you're frozen.
But in the real scenario,
Yeah, now we can hear you.
yeah, so I was just saying that in real time scenario, let's that means in outside scenario, outside Tata, it can be done for all kinds of geriatric patients and all diseases. In Tata, we are concentrating on cancer patients exclusively, so it is surgical, medical, all kinds of cancer patients. But if one day, how I perceive it is that if you are above 60, you get a geriatric assessment done, you understand what is the meaning of quality of life. You don't have to live a poor quality of life and suffer the disease, when you can do something much better with what you have. So that's what I am aiming and hoping that eventually people will understand the importance of it.
Yeah. No, this is just amazing. In fact, when you think of oncology, you always think of just saving lives. And the moment you bring geriatrics into the picture, you're talking about quality of life, well being, and making the patient feel whole and, uh, be in that state of mind that will actually help them uh, maybe combat the disease in some way just because they have the right mindset. And the other important thing is everybody above the age of 60 to have a context to say that the same line of treatment, irrespective of the condition or the disease, will not be the same because that medical trials happen on younger people. So ask for an assessment. And what we've discussed today is really the importance of geriatric oncology in India. And what we've also talked about is why older persons above the age of 60 need a very specially different curated approach to themselves. And because we are in that sense a younger older cohort, because in India we are 60 by the time we come into this category. In the US it is 65, in Europe it's 70. We actually have a 10 years lead time in a sense to have a much better quality of life and make aging. And I like the blog where Anita talks about defeating aging. So, as something that she's coined. So, defeating, combating, fighting disease or conditions which are less than optimal. So, Dr. Vanita Noronha and Dr. Anita Kumar, our guests today, are both doctors at the Tata Memorial Hospital at the Geriatric Oncology Clinic. Thank you so much for being our Lumière Learning Monday guests and sharing your nuggets of wisdom, your knowledge, your experience and expertise with us. We have to apologize to your patients in the OPD who we pulled you out for the purpose of education. So thank you so much.
It has been such a pleasure, Deepa. Thank you so much for having us.
Thank you. Thank you very much.
Bye.
Bye.